Placental function and dysfunction. Normally, in normal pregnancy, we're going to be seeing in the first semester the connection of the cells called extravilous trophoblast with the spiral arteries on the maternal side. And of course, these special invasive cells are coming from the embryo membrane sides. The extravilous trophoblast has the properties to invade using matrix metalloproteinase. They also have the property to connect with the spiral artery to guarantee the perfusion of the embryo. During the second and third semester, after the placenta is already implanted in the endometrium, we need to see a little space in between those syncytial trophoblasts, which is normal, and it is important to progress in the pregnancy in a normal way. Here we can see special cells called the uterine natural killer cells, which have a very important function during the invasion, but also during the permanence of the pregnancy during the 9th month. So, uterine natural killer are going to secrete one interleukin that has been mentioned for tolerance activity. This interleukin is called interleukin 10. Interleukin 10 has the property to lower the cytotoxic functions of the natural killer cells. This will provide the opportunity of the syncytial trophoblast cells to invade the mother's tissue with not getting rejected. The other things that natural killer secretes are growth factors. Part of those growth factors are the endothelium growth factors, VEGF, which main function is to produce new vessels. So it has an angiogenesis function. We also have angiopoietin 2 and also some specific cytokines like interferon gamma. When we have a first trimester abortion, what occurs is that we have a malstructure of the extravilous trophoblast invasion with the lack of connection between the tips of the arteries with the syncytial trophoblast part. The consequence is going to be hypoxia to the embryo, and which follows is an spontaneous abortion. If we do not have a correct connection between the spiral arteries and the trophoblast, we're going to see hypoxia, but also the recurrence of ischemia and reperfusion. Inflammation will pick in with neutrophils and also macrophage. In the case of preeclampsia and or preeclampsia with intrauterine growth retardation, it is mainly the same pathogenesis. It's also based on a dysfunction of the perfusion between the mother's blood going to the placenta and to the embryo. So, the pathogenesis of preeclampsia starts with ischemia and reperfusion. At the end of the day, this will produce hypoxia with an increase of the oxidative stress and also of the products of oxygen that you know, that you know with an active pro-oxidative enzymes like the NOx and the NOS producing nitric oxide. Nitric oxide is the key element responsible for the oxidative stress environment. That oxidative stress environment will produce a systemic inflammation, and that is why we are seeing elevated white cells, specifically neutrophils, and antigen presenting cells like macrophage in a preeclampsia event. The other part has to do with endothelial dysfunction. In the endothelium, we're going to see thrombus formation. So we have thrombogenesis. The other thing that we're going to see, you see that arachidonic acid and COX are going to be forming thromboxanes A2, which is responsible for vasoconstriction. Also, we have ET1 and angiotensin here, also responsible for vasoconstriction. Thrombogenesis plus vasoconstriction are going to be responsible for hypertension and also for multi-organ dysfunction in the cardiovascular system, renal system, and digestive system.